1 o'clock here on my end. Welcome to our webinar this afternoon. My name is Sarah Webster, and I'm a knowledge broker with Niagara Connects. We've also got on the phone today, of course, our lovely presenters. We have our Executive Director, Mary Wiley, and also Liz Lusk, who's providing KB support services, and she'll be helping us today with the technology as well. And of course, we have all of you on the phone, and thank you for taking the time today. So I'm going to give you just a bit of a rundown of the technology itself, and then we'll jump right into the presentation, which I know we're all excited about. So if you haven't participated in a webinar with us before, you'll see that there's the slides in the center of your screen, and those will move on their own as we advance through the presentation. Down the left-hand side is a chat pod. Right now, all of the participant lines are muted, and that kind of helps us cut down on dogs barking and fire alarms going off and all those kind of environmental noises, as well as we know that a lot of people join in groups. So muting the lines allows you to chat and have conversations in the background as well without detracting from the presentation itself. So if you have any questions throughout the presentation, please feel free to use that chat pod on the left. Just type in your question and press enter, and we'll get it on our end, and we'll flag it then for discussion at the end of the presentation. So you'll see we'll go through the presentation itself, and then we'll have time at the end for a discussion, and at that time we'll use the chat pod, and we'll also tell you how to unmute your lines then to speak up and ask any questions or comments at that time. In addition, we also record all of our webinars through Niagara Connects. We're excited. This is our first one of 2015, and the first of at least a few more to come. So the recordings themselves are made available within about a week on the Niagara Knowledge Exchange. And as participants and registrants of this webinar, we'll send you a direct link, like an email, with a link to that recording, so that if you've missed it, you of course get to listen to it. If you want to listen to it again, you can. And we encourage you to share it with your colleagues as well. I think that's it from me. I'm going to turn it over now to our lovely presenters. We've got Dee, Joanne, and Ian all queued up today to share some really cool stuff with us. So I will turn it over to Joanne.
Thank you, Sarah. Welcome, everybody. We are excited to have you all join us here today. We thank you for taking the time to join us today. We hope that the information and the community recommendations do speak to each and every one of you. Just begin a little bit of a background on the Niagara Suicide Prevention Coalition. We have actually been engaging the community for over 10 years. Our purpose is really to build strong and lasting community partnerships. To kind of work together to implement our suicide prevention strategy, to address all the needs of all Niagara residents, to reflect the values of a caring, compassionate community. The coalition does not provide direct services. Our focus is on suicide prevention, intervention, and postvention, which includes public education and training, research and evaluation, means reduction, and access to services. The coalition is a non-funded coalition, so every member is volunteers that work within their capacity at their employment. Working in suicide prevention can be a large task and seem very complex. We definitely don't view ourselves as experts in suicide prevention, intervention, or postvention, but more as advocates working collectively to help Niagara really become a suicide-safer community. Our mandate definitely is to bring interested community organizations, groups, individuals, and volunteers together to make Niagara a suicide-safer community. And we would not be able to, as mentioned before, the coalition is a non-funded coalition. Therefore, it is through the collaboration that NSPC is able to have a presence. It's its community members are made up of agencies, including those listed above, just to name a few, and the work of the coalition would not be able to be or would not be able to be carried out without its members. So we can't thank them enough for the time, the energy, their dedication to trying to make Niagara a suicide-safer community.
It's Dee, and I wanted to say welcome to everybody as well. We wanted to talk a couple minutes about how the Niagara Suicide Prevention Coalition fits together with the Niagara Mental Health and Addiction Charter. And just overall, we know that charters help us to guide policy making and to influence community action. And specifically in Niagara, what the charter is aiming to do is create a common agenda that's going to focus on optimal health and well-being for all people in Niagara, and really to promote a vision of mental wellness in Niagara that's informed by evidence and by community expert opinion. And when we look at the charter, it wants to take an inclusive, holistic, preventative, individual and family-centered approach, which is across the lifespan. And these values match really nicely with the Niagara Suicide Prevention Coalition. And what the charter is going to help us do is advance actions such as interagency collaboration, individual-centered service delivery, and evidence-informed and focused planning. So in November of 2014, there was a working session that identified the themes, the following themes, so everybody can see the, whoops, sorry, I didn't advance the slide. Sarah's going to help me advance the slides. Sorry, Sarah. Thank you. So these were the themes that were identified as priorities for Niagara. And as you can see, the Niagara Suicide Prevention Coalition emerged as one of those priorities. And that's where the collaboration began, is that the NSPC is participating as a working group to ensure that suicide and self-harm are going to be addressed within the implementation phase of the Niagara Mental Health and Addiction Charter. So it's a mutually beneficial goal that's really going to meet that need for Niagara to be a suicide-safer community. So really everybody working together. So as the relationship was developing between the Mental Health and Addiction Charter group and the Niagara Suicide Prevention Coalition, the coalition was developing and undertaking a community review, which Ian's going to talk about.
Thanks, Dee and Joanne. This is Ian here. Before I get into the community review, I just want to say how exciting this is that all the work we've done in the past 4 years has brought us to kind of sharing our suggested action steps forward. And I just want to give a special thanks to Niagara Connects, Public Health, all of our NSPC members, and Carlene Sismar and John, 2 students that really helped gather the information and move this report forward, or this community review forward. But I'll give you a bit of a background on the community review. Sarah, if you could move the slide for me, that would be much appreciated. Thank you. So in 2011, the NSPC kind of regrouped and reevaluated the 2006 strategic plan that's on our website. And in there is lots of information of work that we can do in terms of improving suicide prevention, intervention, and postvention in Niagara. And what we found was there was a need for up-to-date community information and community data. So in 2012, we set out to gather that information, and we gathered information nationally, provincially, and also from each agency that we could that collected any data related to self-harm, suicide ideation, and suicide attempts, and also people who've died by suicide. In 2013, the coalition worked together to review the data and emerged with some themes that we thought were our next steps and the community was ready to address. And I'll go over those today. And those are our suggested action steps. But over the past year, in 2014, we've worked really closely with Niagara Connects and the Niagara Mental Health and Addiction Charter to see how does our work fit within the larger picture of the charter, and how do we work together to have that same reinforcing effect to move these items forward. So I'm going to go over some data about suicide first, and then I'll go over the 6 suggested action steps. So when we look at the national picture, suicide is the 2nd leading cause of death for teenagers and is the leading cause of death for non-accidental deaths. In Ontario, there's approximately 1,000 deaths by suicide per year. And when we look at Niagara specifically, on average, 45 people die by suicide per year, which is around 1 every 8 days. And if we look at even more data, the highest age range for those 45 people would be from 40 to 55. When we look at more specific agency statistics, we see that in 2011, there was 831 ER visits related to self-harm and suicide at our Niagara Health hospitals. When we look at hospital admissions, there was 289 in 2011. We also got some information from Niagara Emergency Services, and over the 3 years of 2010 to 2012, on average, they had 618 people dealing with self-harm, suicide attempts, and or suicide ideation. So that's just a small picture of the Niagara data. But if we can go to the next slide, I will talk about each action step that data kind of informed us to look at what are our next steps as a coalition. So keeping with our format, we like to look at things from where's some work in terms of prevention, where's some work in terms of the intervention stage when people are suicidal here and now, and what about postvention? How do we help the people that have lost a loved one to suicide or has been struggling with suicide themselves and is looking for support? So we kind of framed the 6 suggested action steps into these 3 categories, and I'll review each of them individually, but the 6 are listed there. So I'll move to the first one first, collective data sharing. So in the community review, we found that the data was problematic in a few regards. It was either inconsistent between how the data was reported and how people define self-harm and suicide. There was times looking at community data where it's likely duplicate. So if we're looking at Niagara Regional or EMS data and the hospital data, there's probably overlap there. And we also found that the data is not timely, that because of how it's processed provincially and the information gets to us, we don't get it quick enough to have a good community response. The other piece is we know through other research that suicide is typically underreported, and that's typically because of how suicide is defined. So typically the coroner needs to have intent clear before it can be classified as a suicide, and if it's not, it's classified as an accidental death or specific to whatever the cause of death was, which skews the picture of what's actually going on in Niagara. So the suggestions that came through that is very similar to the suggestions of the Niagara Mental Health and Addiction Charter, that there's a need for a shared measurement system and a need to be able to respond to that as it's happening in the here and now. So we've done some research, and in Scotland they have a national strategy, and they have actually a whole national system of data that we could look at as an example of a shared data system. But also I think the goal is for how can we as a community talk about open data sharing and try to match that specific to suicide so we can respond to what's actually going on in the community and have a more accurate picture. I'm going to backstep. I forgot to mention something, so my apologies if this was unclear. Each of these suggested action steps, the purpose is this is the themes that the community responded to looking at the data we collected. And our call to action here is how can we as a community work together and use our strengths and our assets moving forward to kind of move these items forward. So collective data sharing is a very large one. It could be a 10-year plan. It could be a 3-year plan. These are some things we've noticed and are putting out to the community of how can we use our assets now and try to move forward. And for us, it's specific to suicide and self-harm, but I think more globally within the Mental Health and Addiction Charter, we're all working towards a similar goal. My apologies for not mentioning that before I went into the first suggested action step. But I'll move on to the second one. So a second theme that came from our community review. There was lots of comments about how do we maintain partnerships and increase collaboration in the Niagara region. So many of the feedback that came from the group was navigating the system can be a barrier in terms of doing prevention work or intervention work or even postvention work. So the opportunity now is how do we provide open communication between frontline agency staff to collect input and foster a relational shared learning culture among frontline staff to help reduce system barriers to issues related to suicide and self-harm. So, and I think Niagara Connects and a few other community groups have really shown ways of doing this. So I know putting the pieces together, rowing the boat together are two community examples, and I believe one of the working groups is a mental health and addiction collaboration under the charter. So I think the coalition can definitely take knowledge from this working group and how do we apply it specific to suicide and self-harm. Another group that I think is moving forward with this is the MCYS. Niagara Connect, Contact Niagara got a grant recently and is moving forward with youth-specific suicide prevention work. And I know they're working towards working with primary care providers, which I think is a huge gap, and I think something that is really great that they're moving forward on, and how do we engage them, provide education, and kind of help foster a relationship that helps really provide more collaborative care and reduces those system barriers. So the third one. So the third one is a bit larger. I'll give some history to it first. So in 2012, the NSPC and other community partners agreed that Living Works SafeTALK program, which is a 3-hour suicide education prevention awareness program, would be a good standardized program to use in Niagara. So different agencies and came on board, and there's been over 20 people trained. So I know the school boards, Distress Center, and other community partners have specific members trained as SafeTALK trainers. And since then, last year, the NSPC got a grant from the Niagara Community Foundation to kind of evaluate the program here in Niagara and to train 500 people in suicide. So we're using we want to use this information to help inform how do we make a sustainable SafeTALK program that can be outreached into all Niagara members so we can help create a suicide-safer community. And part of the opportunity here is how do we leverage this information to help build policies so that becomes available and sustainable in our community. So that's kind of the opportunity. And some of the information we got back from that research, just to show you that how effective the program's been. So we've trained 500 people, and one question asked them, how prepared do you feel to talk to someone about suicide? And there was 4 options. The 4 options were not prepared, partly prepared, mostly prepared, and well prepared. And before the training was, before they participated in the training, 65% of the participants said they were not prepared or partly prepared. And after the training, when they took the same survey, 95% of participants said they felt mostly prepared or well prepared. So I think that's exactly what we're looking for, trying to create a culture of having people talk about suicide directly and then connect to the appropriate resources, which is exactly what this program offers. So the call to action here is how do we keep that momentum going to help move the SafeTALK program in a sustainable way. So the fourth one, in the community review, there was a theme of having a standardized response from the community's perspective, including all partners. And over the last couple of years, we've noticed that the youth sector has a protocol specific to assessing violence, and they're working towards a suicide and self-harm one currently. But this doesn't exist within the adult sector across the whole region. So we're trying to move toward suggesting, can we look at this current protocol and how do we adopt it to the adult sector and also help move the youth one forward as well. And then inclusive of that would be standardized assessments. So if I'm working with a client who's from Quest Community Health Center and I need to get them to the hospital, ensuring that language can be shared in terms of risk assessment tools and understanding the whole process from start to finish, so we ensure the client gets the care that he or she needs. The fifth suggested action step was specifically related to crisis services and an agreed upon protocol for mandatory follow-up. So when we did this community review, it was in 2012, and since 2011, the crisis services and mental health and addiction services specific to the hospital, there's been a lot of change. And I think that change is all progressing towards the goals of what the coalition will find beneficial. But with the change, there was comments of how can we keep marketing consistent and available for the community, and then also how do we, there was a big need to identify as a community if we feel anytime reaching out there should be a follow-up to that person who's having thoughts of suicide or attempted suicide in a structured way to ensure that they have the resources needed to them. And I think this is an opportunity of how do, with the resources we have, how do we make that possible? And then the last suggested action step is specific to postvention services. So there's lots of research out there that shows that experience of a suicide, so either knowing someone who's died by suicide or having suicidal thoughts or a suicide attempt yourself is a risk factor for another suicide. So we feel that the need for more postvention services, that was a huge gap that came in our review. The most formal postvention service at the time in 2012 was Loving Outreach, which is a peer support group in Niagara. And since then, there's been a few other, I think, attempts to really provide services to people who are currently experiencing thoughts of suicide in the community. So I know in the past year that the LINS has funded some training for dialectical behavioral therapy and running groups within our community, and I think supporting that gives opportunity for people who are struggling with thoughts of suicide and suicide attempts. And I know there's a peer group that has been run out of Toronto and in Kitchener called Skills for Safer Living Group. And we've looked into that as another support for people who experience thoughts of suicide and have had suicide attempts in the past. And these are two opportunities that I think, moving forward, how do we provide support to this to have more resources available? And then the biggest call to action was how can we have a grief group specific to losing someone to suicide more formalized in our community and having that as a standard support that can be given out to families and friends of people who've died by suicide. So I've kind of gone through the 6 action steps fairly quickly, and I hope they're seen as, this has been an ongoing project for the Niagara Suicide Prevention Coalition, and it's really been trying to pay attention to what's going on in the community and gathering what we've noticed that people are ready to move forward on and opportunities, and how can we put energy forward to help move these kind of items forward, which in our world will help create a suicide-safer community. Again, they're named as suggested action steps for a reason. Our call to action is our next large meeting is on February 4th, and we have more information about that in later slides. But it's about, these are themes that have come out, they're flexible, and how do we, where is your role in helping us move these items forward, and where's our role to help collaborate with what's going on currently in the community to help move these agenda items forward. And how they're shaped out here in the presentation may not look the same in 6 months, and that's okay. It's responding to what's currently going on. So that's it from me. Sarah, I believe you're going to facilitate the discussion, and if I'm wrong, let me know.
Nope, you bet. That sounds good. Thank you, Ian, and Dee and Joanne as well. And I think what you said right there, Ian, actually really resonated with me in terms of this is a fluid process. And I'm thinking even today, as we were preparing this, you were sending me some words on some of these suggested action items, because even since the writing of that document, there's already been some steps taken forward and some changes that have happened. So it's great to see that that momentum is there and it's building, but we know that there's still lots that can be done, and these certainly speak to some of those themes or those areas. So now is the fun part of the call where we get to hear from all of you on the phone. So we've got a couple discussion questions up there for you to kind of consider. You know, does this plan or do these action steps resonate with you? What could you individually or your organization do to support this work? We want to hear from you. And then, is there anything missing? Is there anything missing in terms of an actual theme, or within the themes, is there other steps that have been taken that haven't been mentioned or that you know about that need to be included or on the radar of the NSPC? So I ask you to either type a question or an answer in the chat pod on the left-hand side of your screen, or if you want, you can unmute your individual phone line by pressing *7 and just speak up and let us know what you think. I will pause there for a minute. So Mary asks, how can people connect with and or join the Suicide Prevention Coalition to advance this work?
Our next slide has our email address on there. That's most likely the easiest way to connect. We're currently in transition ourselves. Joanne and I are ending our term as chair, and Dee is taking over. So connecting with our email address, there's probably the easiest way to get a hold of us, because we'll make sure it gets channeled to the right person. And that's nspcc@live.ca. And also showing up to the meeting at February 4th. We're still booking a room actually at this point. So
call for meeting details.
Yeah, so the email is probably the best way to connect with us.
Wonderful. What about, is there anyone on the call today who's already, I know there's people certainly on the call who are already closely involved with NSPC, but what are you doing? I'm going to actually flip back for a minute to the list of action steps, Ian.
Okay.
So that they're all on one screen there. But maybe just consider what you're doing or what area your organization is already focused on. We'd love to hear from you. Kelly asks, what group is doing the training for SafeTALK? And then Francis asks, how can we access SafeTALK? And Milagros asks, how can we access training for our frontline staff? So those kind of all go hand in hand, lots of questions about SafeTALK.
So the easiest way to get in touch with SafeTALK would be connecting with the Stress Center. Lynn Johnstone is the training coordinator, and she could provide information about specific training for your agency if that's what you're looking for, or available trainings in the community. Also, that's probably the simplest answer. If it's going through a school board or if it's going through other specific avenues, there's some agencies have trainers within, but I'm assuming for the people asking those questions, they're looking for more of a community base. So Distress Center would be the easiest to connect with. And Lynn Johnstone is the training coordinator who could help organize that with you.
And Lynn works with the other groups that do the SafeTALK training. So like Ian was saying, that there's some through the school board, through Niagara College. There's different people that are trained, and they all talk on a regular basis to coordinate the training so that we can meet the needs of the community. So definitely Lynn's a good center point to start with, and she'll help you with that.
Anybody else share with us maybe a little bit about what you're doing? Joe also asked here, are there supports for teens, I think it's teens, who have a friend at risk? Thanks.
Yes, so if we look at the crisis services Papstone's Crisis Services is a resource that teens could use. There's just generally the Kids Help phone line. COAST for people above the age of 16 is a crisis line distress center. Could all be a crisis support. But I also know that through public health, the school health program they were running, and of course my mind's going blank on what the program name is, but they were piloting a program last year. And I'll have to get that information to you because I'm blanking on it unless someone can step in and give me the name. But definitely implementing into the schools, and I know each school board has a mental health lead that's really trying to focus on how do we have supports and structure available to the teens in the schools. So they're probably better to answer that question, and I can provide their information for you. And also, public health also has the youth peer support REACT team, which works within the schools. And I know in the last few years they've added mental health to one of their working pods. So they have a whole youth group working towards mental health topics, and I know I've met with them, and they get SafeTALK trained themselves and assist trained on how to address topics such as suicide and mental health within the school. And I know they've been moving forward with that. So there's definitely lots of synergy moving forward in that regard.
Ian, maybe it's something that when we send out this follow-up material with the slides and the link to the recorded presentation, could we also put together some links or further information around SafeTALK as well as some of these other programs, just contact information?
Yeah, that would be great. And thanks, Julie, for YouthNet was the program. And I know they were piloting it. I'm not sure if it's still currently running, but we can definitely have that information available when we do that, what you're suggesting, Sarah.
Perfect. I'm making some notes here then, Ian, on things I'm going to be emailing you about afterwards to put them together. Amanda asks, is anyone aware of a crisis support available via text or live chat for those unable to or uncomfortable with using the phone?
Currently in Niagara, there isn't a crisis service that uses chat or text at this time. If it's for youth specifically, the Kids Help phone line is probably the best resource for that. But in terms of the two crisis services, they don't use live chat or text at this time.
That's a good question that Amanda's asking, because there's definitely a provincial initiative with the distress centers of Ontario to do like a live chat or a text chat. So that is in the works provincially, but again, not here Niagara specific yet. But it's definitely on the agenda.
Julie, thanks for providing more information about YouthNet and that it's an educational type of resource in both schools, school boards currently. So thank you.
And Julie's also said that the app Always There provides live chat via texting.
Oh, yeah.
So that's great. Thank you.
Thank you, Julie.
We've spoken quite a bit on the teen side of things, but Mary asks, is there a trend towards or increased risk of death by suicide among older adults, either generally and or in Niagara, that you know about?
Good question, Mary. Overall, yes, the highest increased risk, which is consistent both provincially, nationally, and in Niagara, is that age range between 40 to 45 is typically the highest, both in males and females, with peaks around 50 to 55 and a little bit younger the same. And then there tends to be peaks in teen years that are less than the midlife and at the end of life as well. But there's consistency in the research or the data that shows person highest at risk or most likely to die by suicide typically is between 40 to 45 or 50 to 55.
Okay. And Linda provided another resource, Francis provided another resource. Your Life Counts is an online support. It isn't live, but you send an email and the response is immediate. So thank you. We'll include that as well in the follow-up materials.
Yes, thanks, Francis. That resource slipped my mind at that moment.
Linda asked, do you have a list of the data and definitions of data that would be helpful for our agency to collect and forward?
Linda, I think that's a really good question, and I think it might be part of that next steps in terms of collective data sharing. I think there needs to be a conversation of how do we define the continuum of suicide ideation, self-harm, and suicide, and how would we collect that? And I think that's a very good question that kind of needs to be discussed at a community level to see what the different ideas are and what's possible. So I'm kind of answering your question with a question, but I think that's a good next step, and I think that's a larger conversation. Because right now, I think the coalition would have some ideas, but I wouldn't want to say this is what we need to do. I think it needs to emerge from what's possible and what are people currently doing.
And Ian, would it be fair to suggest to Linda to reach out via your email to stay in touch as those discussions move forward?
Absolutely. I think that, if the February 4th meeting, that's a really people interested in working on the collective data sharing group, that's a great place to start. I think that's a great question where the group can kind of look at and kind of pull from the data that we have. So this is what we know is happening from the data we collected. What are we missing? What has changed since we gathered this data? And what opportunities are present? And how would we define, and how is it defined best practice across internationally or nationally?
And I think even Linda asking that question, whenever we start kind of dipping our toes into the realm of open data and data sharing and that kind of thing, there can kind of be an instinctual response to kind of keep our own organizational data close at hand, right? Mm-hmm. But this is the right way. It's starting that, being open to that conversation, and also looking at making sure that the definitions of what that data is that you're looking for is consistent across the different organizations. So it will be an important next step for sure.
And I know that Niagara Connects started a open data working group facilitating, and I haven't been able to stay connected to that group, but I believe that there's probably good knowledge that our group can take from what's currently working, and is there things we can use that will work for us.
Are there any other questions or comments? Or Mary, did you want to chime in on any of that related from a Niagara Connects point of view? May have lost her. Are there any other questions? I'm just going to hop ahead. Is there anything that people thought might be missing in terms of the suggested actions items? And I see here Mary has said, on May 1st this year, the 3rd annual Go Open Data Conference will be held in Niagara this year. So perhaps an opportunity to highlight this discussion, which is great, and gives some time, too, to start these conversations locally as well. Thank you, Mary. And that event certainly will also be on the Niagara Knowledge Exchange.
Thanks, Mary, for that information.
And that is an Ontario-wide conference, yeah. But it's always nice when it's held in a local spot for everybody. Catherine asks, can we talk about workplace and prevention of suicide?
So, are you asking what's current practice, or is the question of where's the opportunities?
Catherine, maybe you could clarify either in the chat pod or if you press *7 on your phone and unmute. Where are the opportunities?
Okay, thanks, Catherine. Yeah, the coalition has talked a lot about using the kind of results of our evaluating the SafeTALK project as using it as an equivalent to CPR. So agencies are legislated to have CPR and WMIS for employees, And we feel that this is SafeTALK would be a great 3-hour program to have everyone trained in and give everyone the basic tools around how to identify someone with thoughts of suicide, how to ask someone if they're having thoughts of suicide, how to listen to those thoughts, but then also how to get them to a keep safe person. So it's really about, the program kind of sees it as adding the eyes and ears of our community to, we know when someone may be at risk just by getting to know people, and then giving them the tools to connect with further supports when needed. And it really, the program really opens communication up in a very positive way. So I think some policy development work is, can we work with workplaces around, putting this as a program that could be seen as an equivalent as CPR, because that's, I know members of the coalition, that's what we feel it's the equivalent as, and very much need it. Does that answer your question, Catherine?
To wait for her to type in.
Yeah.
In the meantime,
yeah.
Milagros asks, is there any personal follow-up after a suicide attempt rather than a phone follow-up, as people feel embarrassed or try to go back to their routine?
I really like that question, because right now as the system stands, if someone comes to the attention of a service like COAST, we would do a follow-up call to that person. But at this point, it is generally a phone follow-up. So I think with the action step about the number 5, where it says about the intervention and the mandatory follow-up, that would be a good discussion to have and to look at what are the opportunities for doing outreach, like doing that personal connect with somebody after a suicide attempt. So what could that look like? And Ian had talked a little bit about the group. Remind me of the name, Ian?
Skills for Safer Living.
Yeah, the Skills for Safer Living group, and looking at getting people connected to that. So I really like that question, because it shows me that people are sort of looking at and thinking about how are we going to move this forward, and that's very exciting for us. So I like, it's a good question, and I definitely, is it Milagros that asked that? And I apologize if I'm mispronouncing your name, but definitely would love to have conversations about that, because again, when people are in crisis, there's always the expectation that that person has to reach out to the services, that they have to want the services. So it's a bit of a catch sometimes when somebody's struggling, because they may be resisting. So it's a great question.
I'm going to throw a couple questions out to the group that we've posted in the chat pod there from Mary, just for anyone on the phone to consider and respond to. The first being, could Contact Niagara provide any insights about agencies sharing data, or any of the agencies whose intake goes through Contact Niagara? So I'll leave that. If there is anyone on the phone from Contact Niagara, please do pipe up. And also, could anyone comment on post-secondary campus mental wellness in Niagara, i.e. this is an area of focus for people working at both Niagara College and Brock University? So just something to ponder, and please do respond in the chat pod there if you have any further information about either of those topics. Michelle has asked, just wondering if consideration has been given to support children whose parents are experiencing suicidal tendencies. Given that the age for Niagara was 40 to 50, there's likely children involved.
I think that's a good question. I think formally, there's probably not a formal service specific to that, but I know there's other services that probably help provide support. But it might be a good opportunity to say, is there a need there specific to providing support? But I know the Powerhouse Project is one project that looks at children between certain age groups, and I don't have the age groups with me, whose parents are either struggling with an addiction or mental health and possibly suicide, and providing them an opportunity for support and activity specific on being a child. And then I also think, connecting with Pathstone's Family Counseling Center, any type of family-based service agency would provide that support. And then, I had another one and it slipped my mind. If it comes back to me, I will kind of respond. I will bring that up again. But I think it exists, but maybe not as concretely as specific to the question. The other one I was thinking of is I know Family and Children's Services facilitates with multiple other partnering agencies Strengthening Families program, which is specific to working with both the parents and the children and then bringing them together collaboratively. So it's a pretty comprehensive group that is facilitated through FACTS, and I know I couldn't list all the other partnering agencies, but I know other agencies work with them for that program.
Dee, Mary asked if you could maybe explain a little bit more about COAST and how it
works. Yeah, I noticed that there. The COAST is a crisis outreach and support team. The crisis line number is 1-866-550-5205. And when Ian was talking earlier about the addition of services, when someone calls that number, they'll get an answering machine response, but what it is it's prompting someone to pick one for the crisis line, and then if they select two, what they'll get is the mental health and addiction access line. So if someone's looking for services for someone 16 and over for mental health and addictions, that they can select two. So it's a nice number for people to have, so that if they are in crisis, that they can use the select one, or the option is to press two for mental health and addictions. And what COAST does, it provides mobile support, telephone support, and referrals to appropriate services to the community. So, and again, just to note that COAST isn't a rapid response service. So sometimes, people have to keep in mind that any life-threatening situations, or somebody's worried about someone's immediate safety, that they still need to contact 911. The one thing, because of the partnership with COAST, COAST is partnered with the Niagara Regional Police. So if someone does happen to be in a life-threatening situation, those reports are forwarded to the COAST team after, and then we do the follow-up with that. So there is that follow-up support. Unfortunately, it's not a rapid response, but there is development for a team that's in development for a rapid response, so that the mental health worker and a uniformed officer would respond to the 911 calls that involve the mental health, a mental health call. So that's certainly in development as well. So that'll be a nice addition to the COAST team. Because as it stands right now, COAST is a plainclothes officer and a mental health worker responding to mental health situations. So that's where we're at right now. So lots of, as Ian said, lots going on in the last couple of years with crisis services.
Oh, absolutely. We had a comment come in from Amanda specific to your question, Mary, saying that she works in residence at Brock and has joined the call today with 3 of her colleagues, and this is definitely something that various departments, health services, residents, personal counseling are all working on and talking about on a regular basis, which is fantastic to hear. I think what's great too is when we talk about this topic, so often we kind of focus conversations on whoever the population is, but because we know that there is no specific population, there might be certain age groups that are more likely or less likely and that kind of thing, but really we're talking across the lifespan for suicide support services that are needed. And so I think it's great because what comes out of that is a strength of learning from each other, right? What's happening? What are we doing to support children? What are we doing to support adults, seniors, teens, et cetera? And also thinking, I love the question too about, okay, if a parent's going through suicide thoughts or having suicide thoughts, what are we doing to support the children? So thinking of the family unit and those affected by suicide and suicide thoughts as well.
Well, and just to kind of piggyback on what you're saying, I think even the questions show the multitude and how multifaceted suicide is as a topic. And I think, like you said, it's so broad and in depth of how can we tackle each issue. And something I forgot to mention as well, that's some current work that's going on in the community specific to Postvention is Contact Niagara is facilitating with many community partners, also doing a bit of a research project on working with families and of people who have attempted suicide or have lost someone to suicide to see what services are needed and what would be helpful specific to those families as a postvention service. And I think that also information will probably help inform intervention services and prevention services. So I think there's just a multitude of really good energy happening in our community that I think it's good to acknowledge, and then how can we harness other things that are going on to kind of help move these items forward across all sectors.
Absolutely. Any other questions or comments? I'm going to, as we're kind of having this final discussion, you'll just see some evaluation questions come up on your screen, so please do take a minute to answer those, and then at the end we'll put the contact information back up as well, and add some links into the chat pod to access some of the things we've talked about. Mary asks, or comments, please highlight the centralized intake model for mental health and addiction in Niagara being piloted. Is that something Ian or Joanne or Jake that you could speak to?
So what when someone calls the 1866 number and they select 2, they get the mental health and addiction access line. So what they'll do is the person answering the phone would take the time to listen and see what the person is looking for. And what it is a partnership between there's 17 mental health and addiction programs funded by the Ministry of Health, and what they do is they would help the person connect to the most appropriate service that matches their need. And what they do is they're able to connect, like do a warm transfer or connect with that client to the service, and then they also will do follow-up, so ensuring that people aren't falling through the cracks and making sure that they're getting connected to where they need to be. And again, I should mention as well that the Coast and the Central Access Line are 24-hour services, so anyone can access those 24 hours a day, 7 days a week.
And can you put the Coast, the 1866, I think, number?
Yeah, 1-866-550-5205. And I always like to let people know that when that phone rings, it actually picks up right away with an automated voice to say, select 1 for Coast, select 2 for access line. Because sometimes people are expecting a live answer, so it throws them off. And then when they select their number, just so that they know that the access line worker and the Coast worker, if we're not on the phone with someone else, it is a live answer. So the person will pick up if we're not on the line. If you do happen to if it doesn't go right through, it'll go to an answering machine. So I always like to make sure that people know that as well. And people are certainly welcome to leave a message, and we'll call back.
Joe asks, is there anything being done to decrease the wait lists for counseling? A 3-month wait after an attempt is not effective.
I think that's a really good question, and I think it could be very agency specific, but I know there's been lots of changes within the last 5 years in terms of added crisis services and changes internally within services. So I can name a few, but it's definitely not going to be inclusive. So it will depend on which agency they're looking for counseling and if they have EAP benefits, and it's just a multitude of factors. But I know at CMHA they have their urgent support services team Monday through Friday, 11:30 to 7 at both the St. Catharines location, 15 Wellington Street, and their Niagara Falls location on Morrison Street, the exact address I don't remember. I know on Wednesdays they have a walk-in counseling session, a one-time walk-in counseling session every Wednesday, and I believe that runs from 12 to 6:30, I believe, but the exact time we'll have to provide on afterwards. I know Community Addiction Services of Niagara have moved towards the same-day service, so you can call in the morning and have an appointment booked in the afternoon, I believe. And again, this is my understanding, so more information would be accessing their website, and we'll try to provide that for you afterwards. I know if you're accessing help at a community health center, there's typically a priority setting when an intake's done. So someone who has had a attempt to suicide may be considered a priority to get them seen quicker. But yeah, those are, and then the crisis services that are available, Coast, Distress Center, Papstone's Crisis Services. I know Papstone's has a team working within the school trying to have a rapid response. So I think it depends on which service you're looking for help from, and then their policies around prioritization. So I wouldn't be able to speak to all of it because I'm not sure of all the services, but I hope that answers some of your question.
And also, I know with Access Line, they're endeavoring to have any wait times or anything, like when someone calls into that number, that they would be able to give an indication of how long. So that's part of the protocols between Access Line and the respective agencies. So the client should have an idea right then if there's wait times.
And Derek asks, how is the collaboration with the community services and the hospital changing so that people in suicide crisis will be admitted to hospital?
I think that's a really good question, and I think it goes back to kind of defining, because what I found in my experience of admitting to hospital, it comes down to the risk assessment and a shared definition of what does an admission to hospital require. So I think it's a larger conversation, and I think the community protocol sets a standard and an expectation, and that's consistent among all community members, because I think the experience can be hoping that someone will be admitted and they're not, or vice versa. And typically when you look through, it might be of different expectations of understanding the Mental Health Act, understanding how the client presents before going to hospital versus at hospital. There's lots of factors. So I'm not sure that the collaboration has made any individual changes at this point, but I think the collaboration is definitely identifying what is going on with the system and how do we respond and try to have a standardized measure, because best practice for risk assessment is a structured clinical judgment. So best practice is to use a risk assessment tool, but also include clinical judgment. And with that, there's always a bit of variance.
And I think as well, when somebody isn't admitted because of all the system issues that can be in place, that what's the safety net? So as a community, what's the safety net for someone who's experiencing suicide thoughts or a suicide attempt? So how do we keep them safe? And it's an important question. So, and I think definitely we want to work towards that.
Yeah. Thanks for the question, Derek. It's definitely a good one.
And with that, we have already hit our 2 o'clock time frame. That hour kind of flew by. But I wanted to say a thank you to all of our presenters today. What an interesting conversation for this afternoon, and to everyone on the call, because the discussion itself, I think, is where we saw a lot of value today in some of these really important ideas kind of be coming forward and getting talked about. So as I said, you will receive a communication from us in the next week or so with links to the recording and the slides and some of the other contact information that we've talked about. In addition, I've put up some links there, one to the fleshed out action items that Ian spoke to, as well as a link to our Niagara Connects page to get connected to us. If you're not already receiving our bi-monthly newsletter, sign up there. It's free, and we'll keep you in the know about upcoming webinars, not just our webinars, but also other events in the community, as well as new resources, projects, and blogs that have been added to the Niagara Knowledge Exchange. So other than that, I will sign off today and just say a big thank you to everybody and happy 2015, and enjoy the rest of your afternoon. Take care, everyone.
Thank you.
Thank you.
Thank you.